Well, good morning, everyone. How are you all? Wow, a packed house. I mean, this is great, full house. Give yourselves a round of applause for showing up and packing this place today. I like the energy I'm feeling. Before we get to the program, we have a couple of new commitments that we want to announce to you. And I'm so excited about these young people who are making commitments to better their communities and work in the health sector. First of all, let me tell you about the first group. Their challenge is, it has to do with the Kaiser Family Foundation estimate that nearly a third of all medical expenses incurred by Black, Hispanic, and Asian people are unnecessary and avoidable and result directly from pronounced disparities in primary care. And in addition, less than 12% of minorities possess the basic health literacy skills necessary for managing their health and preventing disease. And according to a recent survey, Black and Hispanic people in Los Angeles County were twice as likely to view cost as a barrier to receiving health care. So we have three young people who really want to do something about this. Gianna Ramos of the University of California, Los Angeles, Francis James of Loyola Marymount University, and also Daniel Waite of the University of California, Los Angeles. So what do they want to do? They have committed to improving health literacy in Boyle Heights, a low-income Hispanic neighborhood in East LA, by teaching local students from Mendez High School to lead health assessments of their community, and based on the results, then create community events to address those community concerns. And once the assessments are completed, the students will work together to identify the top concerns in their community and formulate initiatives to address them. And they hope that by helping young people become invested in the well-being of their communities, they will not only help improve the health of Boyle Heights, but also empower students to become agents of change in their own communities. And so at this point, we want to welcome all three of them to the stage to give them their moment in the sun and recognition. So Gianna Ramos, Francis James, and Daniel Waite, will you come join us? And look at this, we have a wonderful certificate for you to take. Do we have one for each of you, or just one? Sorry, you have to share. You guys know how to share, right? Okay. And are we supposed to do a little photo op here for somebody? Okay, look there. Smile. Do you need me? You don't need me. They're the stars. Give them a round of applause. Congratulations. Good luck. We'll be monitoring your progress. All right. Coming out this way. Now, our next, is an individual. Our next person is Davika Baji of the University of Michigan, Ann Arbor. And the challenge here, according to the World Health Organization, roughly 100,000 people die every day from preventable, treatable, or reversible conditions, most in developing countries that lack the resources and the doctors to manage them. In Sri Lanka, 1 in 3 adults suffer from hypertension or high blood pressure, and nearly 1.5 million people in the region will die unnecessarily from complications related to that disease. It's a condition that's easily managed with lifestyle modifications, low-cost medications, and routine primary care. So, how does Davika want to address this? Together with a team of medical students from the University of Michigan, has committed to using widely available technology to offer hypertension management and regular primary care to elderly residents and young orphans at the Grace Care Center in Trincomalee, Sri Lanka, who currently lack adequate access to medical care. Using telemedicine to bridge the gap, Davika plans to utilize weekly video conferencing and secure cloud-based electronic health records to create a low-cost, data-driven plan to manage hypertension and promote healthier lifestyles. I love how Davika is going to use technology and incorporate it in all this. The center's medical assistants will upload daily blood pressure measurements, which will in turn be evaluated by the University of Michigan doctors. Patients needing follow-up will be seen by video appointment, and these calls will seek to manage hypertension through patient education, lifestyle intervention, and medication regimens that will be carried out by the entire Grace Care staff on site. The team also plans to monitor the pediatric health of the center's girls, many of whom have never received consistent medical care. And through the technological innovations and increased connectivity, Davika and her team believe they can improve the well-being of patients and offer a brand new way to reach the people in need. And so if you can welcome to the stage Davika Bachi. And hey, you don't have to share. You get your very own certificate. How about that? There you go. Smile. You're welcome. Okay, so we're about to begin the panel. And before we do so, just a little bit about me. I was born in Vietnam, in Saigon, which is now Ho Chi Minh City. And my family fled at the end of the war in 1975. I left in a cargo ship designed for 200 people, but 2,000 people were crammed on board trying to flee the chaos and war. And I lived in a couple of refugee camps before resettling in the US, and we were sponsored by a Lutheran church group in Duluth, Minnesota. And so I went from Vietnam to Duluth, Minnesota, as far north as you could get, living across from Lake Superior. So I certainly know about developing countries and the challenges we face. So this panel is very meaningful on a personal level to me as well. And I hope it will be equally engaging to you. Just a little bit about how this is going to work. We have the panel discussion that'll go on for roughly half an hour. There will be time for Q&A, so if you have questions, please feel free to jot them down and kind of keep track of what you want to ask. After closing remarks, we will have an opportunity for all of you to have working groups, talk among yourselves about some of the ideas, and come up with ways that you might want to address some of the challenges you heard. And then we'll come back and have a report back from some of the audience members. Does that sound good? I'm so excited. It's such a packed room. This is good. All right, without further ado, let me get to the right page. By the way, if you had signed on to this program earlier, we were hoping to have Jack Andraga, but unfortunately he couldn't make it due to bad weather on the East Coast. But we're so happy to have three wonderful panelists here with us today. The first is Doyin Oluwole, Executive Director of Pink Ribbon, Red Ribbon. Can you come on up, Doyin? Doyin and I are staying at the same hotel, and we keep on running into each other, so we're tight. We're like best buddies. We're always on the shuttles together. Phil Sutherland, CEO and co-founder of Team Novo Nordisk, and founder and president of Team Type 1 Foundation. And Sonia Shin, Associate Physician, Division of Global Health Equity at Brigham and Women's Hospital. Welcome to you all. So I just wanted to open up with a startling statistic that I had read about as I was doing research for this panel. According to the Council on Foreign Relations, a recent report by them, cancer, cardiovascular disease, diabetes, and other non-communicable diseases killed more than 8 million people under 60 in 2013 alone, in 1 year alone, in low and middle income countries. And these rates are continuing to rise at an alarming pace. And given that backdrop, I wanted to open this question to all three of you. There doesn't seem to be much public awareness, and I'll be honest, I didn't even know about this before I was invited to moderate the panel, and before I started researching, I didn't realize what an emerging crisis it is. And so if people in the news who make it our business to know what's going on in the news don't know, or maybe I'm just more ignorant than my counterparts, I don't know. But I mean, if I don't know, and so many of my friends in the business don't know, because I started talking to them about it and they were equally shocked, why do you think there's not more public awareness, and what can we do to create more public engagement? And Doyin, I'll open it up to you.
Well, first, let me say thank you for having me here today. I bring warm greetings from the George W. Bush Presidential Center in Dallas, Texas. Thanks for the question, Tui. I'd like to illustrate with an incident that happened in Houston last August. President Teshome of Ethiopia was visiting MD Anderson Cancer Institute, one of the top institutes that deal with cancer in the world. And he posed a question to the president of MD Anderson. He said, "Is it possible to make cancer history?" And Ron DePinho responded and said, "We believe it is, but we are not yet there. To get to that point, we would need to wage a global war on cancer." End of quote. And you can replace the word cancer with non-communicable diseases. To be able to wage a global war on non-communicable diseases, you need global, national, and local champions. In Pink Ribbon, Red Ribbon, we are focused on cancer, and we have employed some of those platforms, especially first ladies of developing countries. They are considered as the mother of the nation. And when they speak, people trust them. They believe them. They come out and do what they ask them to do. These people have helped us in Zambia, Ethiopia, and Tanzania. The first lady, the former first lady of Zambia, set herself a goal of a Zambia country that is cancer-free. And she actually went all out to implement programs alongside with the Ministry of Health to mobilize women. The result is that since our engagement in that country, we have supported them to screen over 120,000 women who never would have been screened. On March 8, 2014, the First Lady of Tanzania came out and said to the women, "Come, it is not a stigma to be diagnosed with cancer. Come out and be screened." Over 12,000 men and women came out, and on that day alone, 3,000 plus women were screened for cervical cancer. And within a week, over 5,000 women were screened for breast cancer who never would have been screened. So those kinds of champions are needed. Secondly, we need political will. Political will that's willing to invest in non-communicable diseases. Thirdly, we need the evidence. As you said to us earlier on, Tui, you read about it, you saw the numbers. It's beyond the numbers. Behind each of those numbers is a human being. And we know that as of last year, all of you probably are aware of maternal mortality being a big issue in the world. But we now know that more women are dying of cervical cancer globally than maternal deaths. So when you have the evidence, when you have the champions, when you have the political will, you can engage the global community.
And I want to ask Phil about that, because this segues right into something we had been talking about on the way here, right, Phil? The political will. Talk about how important that is in your work in Rwanda.
Yeah, I mean, so a couple things. It's, we have to raise the awareness for the problem for NCDs. It's really unfortunate that, in the US, 80% of people who live from cancer, 20% die. You go to the developing world, that's flipped. 20% live and 80% die. But most of us here in the US aren't aware of that. In the US, when you have type 1 diabetes, as I have for 33 years, you can do whatever you want. You can go out there and pursue your dreams, pursue your goals, because you have access to education, you have access to treatment. In Rwanda and most of sub-Saharan Africa, 7 out of 8 die before they ever get a chance to get diagnosed. And then once diagnosed, the life expectancy is 7 months, to 7 years. You live 7 years if you're lucky, but usually you've lost a leg, you're blind, and by this point, your family's abandoned you. So, how do we raise this awareness? because to be frank, I was just like you, Twee. I was ignorant until I actually went to the developing world and I saw what the problem was. And then on the ground, when I see these kids who now have access to medicine and how excited they are to take care of it, and the fact that they see others with athletes with diabetes, which is what I brought to the country, say, if they can do it, I can do it. You provide hope. And so, I'm blessed to be here in this room of the youth, because I think youth can change. And from an awareness raiser here in America, because it is here that we can solve the problem. As President Bush did with the PEPFAR program, which created access to HIV medication and treatment all around the world, we need to replicate that for the NCDs. But we need voices to speak out on behalf of that. And so I do believe in the youth. I started my Team Type 1 when I was in college. I was a senior for the second time at the University of Georgia. And I saw a problem of people lacking motivation to take care of themselves. So I began via the bicycle, getting out there and telling people, take care of yourself, check your blood sugar, do your shots, you can achieve your dreams. Fast forward 10 years, I have a professional cycling team comprised of all of athletes with diabetes racing all over the world. We race against the best of the best to educate, empower, and inspire, and that's done through a partnership with Novo Nordisk called Team Novo Nordisk. Now, Team Type 1 Foundation. Again, I really believe in the youth. I believe you all here are agents of change if you're willing to A, have passion, and B, be persistent. Because it's not easy. You're going to get told no again and again and again, but every no that you hear is really just one step closer to the yes. And so at the foundation, we provided a million test strips, a year's worth of diabetes supplies to the Rwanda Minister of Health. My wife in 2011 showed me that government is key. I met her in Macedonia, and she ensured that everyone in Macedonia had access to the treatment needed to live and to thrive with diabetes. And so I stole her from Macedonia, married her, and now I've employed her to manage the governmental relationships for my foundation, which, trust me, it's great to raise awareness, but it's even better to really create sustainable action, which is what she's doing and what she's very good at. But second, I want to go back to the youth and how you can change. Last year I provided 18 college scholarships to athletes with type 1 diabetes, to help engage them as leaders and to help use their sports as a platform to motivate others, to raise this voice. In fact, this year, we've got 62 applications, and I plan to fund all of them, because these are kids who want to use their sports and their disease as a platform to create change. And I just want to reiterate again, you're in college. Use your naivety, the fact that you believe things can get done. You believe that you can make change, and guess what, you can. Because if I stopped every time someone told me I couldn't do it, I'd have been dead 30 years ago. But you persist, and you learn lessons, and you're going to make mistakes. But you have to be vocal, you have to be active, and you have to try to raise the money and then invest in the right places to raise the voice. Getting the first ladies of the countries involved to raise awareness, that's amazing. That's creating scale. Getting people screened to find out who has to have the conditions, that's saving lives, because that's going to provide them access to treatment. And that's what we're doing in Rwanda, and it's a model we're being requested to work in other countries such as Haiti, Ethiopia, and we're exploring opportunities to figure out where the next place to go. And my dream is, by 2021, and I'll finish with this, insulin was invented in 1921. And my goal is that by 2021, to celebrate the 100th year of life for my people, we can ensure access to medicine and a chance for life for every single one of them. So if there's any of you public health geniuses out there that really have an interest in diabetes, come find me afterwards, because we're looking to change the world and we need good people to help us do so.
And Sonia, through your work with the Navajo Nation, what are some of the best lessons and best practices you've learned about creating public engagement? And more importantly, did you also steal a potential spouse from anywhere?
Right. I'm starting to hear this theme of relationships, so marry well, pick your partners. And I feel very fortunate because I did pick a good partner who puts up with my work. I think that this concept of really forming strong relationships of trust with your communities is really key. So I've worked in Partners in Health for about 20 years, and some of you might be familiar with that. And then having worked in places like Peru and Haiti and Russia, about 5 years ago I came to Navajo Nation to partner with what is essentially a developing country, a sovereign nation in our United States. So one of my, sort of soapbox issues is that when we talk about global health, it's really important to remember that, like some of the students that are here and were acknowledged this morning, these are issues in the United States as well, and the same kind of factors of poverty and lack of access to care, income inequality are driving, disparities in chronic diseases in the United States, and in particular in communities of color. So I just, really want to emphasize that, this is the global community. In Navajo, I think what has been really important is working with community health workers who are usually women. They're usually people who are, in the community, they speak Navajo, and they're the ones who have mentored us to tell us, what to do, what's important. And an example that I'll take is food access. So we're working, not only to help people who are living with uncontrolled diseases like cancer, like diabetes, manage their illness, and also their children, to prevent disease. But at the end of the day, what's driving these epidemics, at least in Navajo, is lack of access to healthy food. So you're in a very, very rural community, and some of these families might have to drive 100 miles to get to a grocery store. If you don't have a car, you're going to do that maybe once a month. If you don't have a fridge, what are you going to buy? So, when we started to think about, okay, in order to really kind of put a dent into this epidemic, we're going to have to deal with food security. And we talked to community members, to elected officials, to community health representatives. And, what we heard was that not only do we have to think about bringing food into the communities where people can purchase them, like for instance these small stores, these little convenience stores, which is where we're going to focus. But also, you can't just truck food in and drop it off. It actually just reinforces sort of a cycle of dependence, and rather you have to think about a way to actually empower the community and actually use this food access work to defend what many Navajo feel is a critical issue, which is food sovereignty. Do we have control over our food system? Is it all imported food, or can we, really promote our traditional foods and our sacred connection to food? So, that really changed the landscape of how, me as a physician thinking about health outcomes, diabetes, et cetera, how can I come up with a project that's going to actually increase food, while respecting these really, really fundamental goals that are connected to something, as culturally important as food. So, at the end of the day, what we're starting now is this Healthy Store Initiative, where we're really trying to link these small stores to local growers, and actually help local community members spend their money on the reservation in these local businesses, as opposed to letting the money, sort of drain off the reservation. So at the end of, it's not just a food access project, but it's really a community development project, and in some ways meant to kind of empower, that social fabric within the community.
Okay, and I'm going to take my license now as the moderator to because we've got about 12 minutes left in this session, and there are a number of questions I want to get through. So we will aim for some short, almost lightning round answers to the next set of questions. And I'll go in reverse order this time, Sonia. Yesterday at the plenary session, I don't know how many of you went, but there was a lot of talk about how often when you do this kind of work, in any line of work actually, not just health work, but my work, media work, it's sometimes not so much talent and experience that matters most, is passion and perseverance. And the people in my industry who rise at the top are people who are passionate and persevere. Same thing with you guys, right? So in your line of work, is there one particular anecdote that you can tell us, whether it's a particular instance, an incident, or a person who touched your life so deeply that kept that passion going, that you can share with us, and what you learned from it? Sonia, beginning with you.
Well, the anecdote that comes to mind is actually not necessarily a happy one, but it's, when I was working in Peru, I was working around tuberculosis work, and there was a patient who I had looked after for many months, who actually never started treatment, and ultimately, he died. And I think he had probably something like 10 HIV tests during that period. So he was like in care, you know, he was actually at the door really, you know, begging for treatment. And yet because he wasn't sort of seen as somebody who would kind of be like a model patient, he was really kind of just continually turned away. You know, so I think that even with technology and even with access to medications, even with insulin and you know, even better drugs in the future, you know, really just making sure that we're all, you know, kind of humbled by the fact that each person, no matter who they are, you know, whether they're homeless or mentally ill or, you know, a substance user, what have you, they all really need access to care. So that's kind of our role, you know, is to make sure that really the playing field is leveled for everyone. So.
Bill?
And mine was after my first visit to Rwanda in November of 2010. We just completed the tour of Rwanda, this bike race, and we'd worked on, met a lot of kids with diabetes and seen what it's really like there. We brought $40,000 worth of supplies in to give to the kids so everyone had access to a meter. But the touching moment for me was as I was driving to the airport, the president of the Rwanda Diabetes Association, Francois Gishoma, said to me, Phil, I just want to say thank you. We tell our kids every single day that they're going to be okay, that they're going to be okay. We try to give them hope. But they look at us like we're liars, because everyone they have ever known with diabetes has died a miserable death from this disease. But after they looked and they saw your team and they saw 6 athletes and they saw you having lived with diabetes for 28 years, they said for the last 2 weeks they came to our clinic and they believed. He said for the first time in the world, in their lives, they have hope. Thank you, that's priceless. And for me, this was a trip that nearly bankrupted my company. Yeah, it did. We finished in 2010 with $436 in the bank account. But it was the right thing to do. And I knew we had to do it. And hearing Francois say those words really inspired me to come home and fight to get the resource to go back and do it better. And again, I'll give credit to my better half, my wife, who's now taking the governmental perspective and is working directly with the Minister of Health in Rwanda to enable her to take care of these kids on our own after one day we leave the country. So, I mean, you're going to have a lot of those aha moments, and that was one that, I remember it like it was yesterday, and it's, we will go there until we finish.
Thank you for that. Joyine?
Yes, my first day at work, which was a little over 3 years ago on this job, I went in to get a briefing from President George Bush. And he said to me, Doyin, this work that you are coming into, it's not about Laura, it's not about me, it is bigger than us, it is about the women in Africa, it is about saving lives. Look beyond us, because even after we have gone, we want this to remain. It's about saving lives. And so even as these 4 people and the rest of you have plans, go out there to do whatever it is. It's not about you. It's not about me. It's about the lives you are impacting. That woman whose life you will save will help to save the lives of her children, would contribute to the economy of her family, her community, her nation, and thereby you are touching the world.
That is so true. Thank you, Joyine. And as I look around and I see all your young faces, it really is very energizing. I used to teach journalism as well for 4 semesters until I ran out of time. But I love college students. I really do. Your optimism and your idealism and your go-get-'em attitude is just amazing and fills me with pride and hope for this next generation. And so I want to ask the 3 of you, we've heard a lot about what works for you. What did not work? What can you teach this audience here about things you've tried that didn't work or presumptions that you came into a project with that just got blown out of the water? And Phil, this time I'll start with you.
Yeah, well, this is a difficult question. Let me list all the mistakes I've made over the last 10 years. We're going to need a few
we
days.
only have 6 minutes left.
Okay, well then I'll try to stick to one basic principle, which is, it's easy to come in and think that you can solve the problem based on your knowledge from the outside. But what you have to learn is, especially if you're going to go into a local community here in the States or some developing country around the world, is you have to understand their community. You have to understand how they do things and their systems, their culture, and you have to build your program to fit them and let them guide you. And it's really engaging with local partnerships and helping the local partners guide you for success. Because if you take your model and think that your model is going to work, it will fail. But really working together, it's about partnership. And I think that's why CGI is so invaluable, because it just really encourages partnerships. It's tough to do things on your own, but if you can partner with people, whether it's the kids in the community, to go out there and make a difference, or it's the Minister of Health who's going to allow you to make the difference, or the First Lady, which you're much higher up in people than I am. Congratulations. It's about those partnerships which ensure success. So do it their way and throw in your passion and enthusiasm, and you'll succeed.
Sonia?
Well, I want to sort of build on what you're saying, because my answer is actually pretty similar. And I would add that, that's what makes it gratifying for all of us as well. You learn so much because it's about that relationship and being taught by, your community that you're partnering with. So I think, when you do go into a community, and many of you have already made that commitment, I mean, that word commitment is really important. You're kind of not there for the quick fix. You're not there, the time course, the life course of your work won't be determined by you alone. It's going to be determined by the community, and they're going to tell you, when you're done. So just make sure that you're ready for that kind of commitment. It's a little bit like marriage, maybe.
So for me, it's been challenging to look at the entire continuum of cancer care. When you look at it from primary prevention right through to tertiary, including surgery, chemotherapy, radiotherapy, palliative care, it is very complex. We've done very well with the basic screening, applying a very low-cost proven intervention using household vinegar. The same household vinegar that we all use. Training nurses to put a drop of it on the cervix, take a look, and they are able to tell whether it's a normal or abnormal cervix. To that extent, in the last 2-3 years, we have been able to support 3 countries to screen over 150,000 women. But amongst those who were screened were cases of suspected cancer. What has not worked well for us is how to connect these ladies who are in the rural areas to the only cancer center that may be 2,000 plus kilometers away from where they live. It is challenging. How have we done it? Back to what they're talking about, partnerships. For example, we just had signed a contract with Vodacom Tanzania, a telephone company who has given us money to pay for transportation for these women from their homes to a cancer center, the only cancer center serving 43 million people in Tanzania. That means when that woman gets the diagnosis or a suspicion of cancer, she does not have to sell the only goats that she has or her clothes to be able to transport herself to the capital. We provide that money, and she gets to the center, she gets free treatment, and we pay for her to go back home at the end of treatment.
I'm so glad you brought that up. I mean, that's a great example of innovative thinking, right? A phone company partnering to make a difference, in this case, in cervical cancer care. And I think that's incredible.
The reason it's a phone company is that we use a mobile system of funds transfer. The woman doesn't get the money because she may spend it on food. But we use a mobile system called M-Pesa, which Vodacom has developed in the country. We transfer the money to an expediter who gets her onto the bus, and make sure that she gets back home.
I love that. So to wrap up the panel discussion, what is the best piece of advice anyone has given the three of you, and what's the best piece of advice you have to give to everyone here in this room? And Doyen, you get to start.
The best advice I have received and which has paid up for me is be flexible, patient, and persevering. Flexible in the sense that every country that we go into, you cannot import the experience of the prior country and say we're going to do it exactly the same way. As you heard from Phil and Sonia, you've got to listen to the people and be flexible in your approach. That way, they get to own it and lead it. Be patient, because you have to work with lots of partners on ground. Beginning with the girls that need to be vaccinated, explaining to them, this is not to sterilize you, it is actually to prevent you from becoming a cervical cancer patient in future. And through this process, we've been able to support 2 countries to vaccinate over 42,000 girls.
Wonderful numbers.
Within
Great
2
advice.
years.
Thank you, Doyen.
So that is something that I would like to pass on to you. Be very flexible, be patient, and persevere. Even against all odds, there is always the light at the end of the tunnel.
Phil?
Whether you think you can or you think you can't, you're probably right. So believe in yourself and go forward.
That's great. I'm going to steal that for the next time I'm on a panel. Anybody want to invite me to be on a panel? Sonia?
Well, the best advice that I was given, maybe not the best, but it's held true, is always pack a fleece. I know you might not believe me, but just trust me, it's going to turn out to be true. And I guess, like, if I were going to give all of you advice, I would just say, you know, to see the positive. You know, so it can be really jarring, and it can take a lot out of us to work in countries, you know, of poverty. But what I've learned is that, you know, in every community, there's so much strength, there's so much internal resilience. And so if you can kind of see that positive and harness that and really kind of support that strength that already exists within communities, I think that's actually really helpful, and it also sort of keeps you sustained in your work.
Okay, and I would like to open up at this point to a Q&A. I think we have time for maybe a couple of questions. Does anybody have a question that you'd like to ask of our 3 panelists? And we have mic runners out there, so just raise your hand and they'll bring a mic over to you.
Thank you. Thank you for being on the panel. Okay, my question was related to kind of the balance that I think Phil spoke to as his wife working with the government and kind of initiatives of health education and kind of where the impetus lies on like addressing chronic disease.
Yeah, it's often underfunded, and it's often underfunded because there's a lack of education. And yeah, I went and when I met my wife, I'd given a talk to the University of Skopje, and I was invited after my talk to meet with her and her boss, and I just drew a graph. I said, if you invest what you're investing now in people with diabetes, then 10, 15, 20 years down the road, you're going to have an incapable work population. You're going to be paying for renal failure, for amputations, for cardiovascular problems, which you pay for as a government. Yes. So I said, if you invest a little bit more now, pay for test strips, pay for insulin pumps, it's an incrementally higher investment now, but the cost over time will decrease, and you'll have a very work-capable population. I've said that a number of times, but my wife went to work, and what she did is she wrote letters on behalf of her minister to the WHO to reallocate dollars that they had funding for HIV, which they no longer needed in Macedonia, to allocate those dollars to people with diabetes. So 38,000 people with diabetes type 2 had 2+ test strips a day. And if you had type 1 diabetes, you had 6 to 15 test strips a day basal bolus insulin therapy, and even insulin pumps paid for 100% by the government. They began to invest in their people, and they've seen an immense return on investment in that. And that's kind of the model that we're trying to take, is that it's not just dollars for healthcare, but it's investing in your people. Because I've got 100 plus athletes with diabetes who are all out there competing in sport. Many of them have, like, I've got an amateur program, they have other jobs, they have families, they're work capable. And the investment in them is, then turning into dollars into the economy versus economies suck, which can be done if you don't properly care for them. And I think, a lot of what Sonia is dealing with in the Navajo, it's getting people to exercise, it's prevention. Because the type 2, is a prevention model, and people just need to be more aware that they, if we're asking governments to invest in people, we also have to ask people to invest in themselves, and that means making smart choices, exercising, trying to eat healthier, and then taking care of yourself, because you can work all day long, but do you want to work 15 hours a day so that you die at 55 because you didn't take care of yourself, or do you want to focus on yourself a little bit so that you can live till you're 75, 85, and see your grandkids grow up? So it's trying to balance the two of education at the very high level, but also still touching at the grassroots to show people that, if we give you these tools, then we need you to take care of them and then become productive members of society.
We have another question? Oh, a lot of hands, okay.
Hello, my name is Kirsten Dimovitz, and my question is specifically for Phil, but I would like to hear your opinions, all of you on the panel. This is kind of a good segue. We talked a little bit about personalized medicine and the awareness that you created. And I'm wondering, since we came from a talk on big data, what you see the role of that is in diabetes care, and also if there's a difference between what that looks like in the US and what that looks like in developing countries.
Yep, it's a great question. And I think there's a lot of movement being done here in the US. There's kids who have continuous glucose monitors, and their parents, this hacking group, created and they've got 10,000 members now, called Night Scout, and they can watch their kids' blood sugar at school on their watch, right? And so they're able, if they see something going wrong, they can call the school to prevent that kid from ever having to say, I can't take my test now because I'm low, or I can't go play because my blood sugar's too low. So technology is allowing for prevention of bad scenarios here. But you look to the developing world, there's telemedicine these days. Like in a lot of the clinics, as was mentioned previously, people don't actually have access to get to a doctor. But a doctor on FaceTime can look at you and diagnose some problems and maybe run through some changes. There's a doctor in Macedonia who lowered hemoglobin A1C for people with diabetes by communicating with them Facebook. These are kids. Kids don't want to hear from their parents. Kids don't want to hear from their doctors. But when they're communicating to someone on Facebook, it's cool. And because it was Facebook, they were actually empowered to start taking control. And we saw outcomes via study that were just, they put America and the rest of the world to shame for what they were able to do just by thinking outside the box. So I think there's definitely a place for big data. I think, first we have to ensure, life, which is insulin, which is test strips, and then we can start really refining the model to see how we can pull some of this data and not just pull them forward 10 years, because right now in Rwanda, they're about 40 years behind us on a diabetes perspective, but we can fast forward them 30 years very quickly. And I think the big data, if any big thinkers out there want to think about diabetes, it's a very lucrative possibility, being that there's 380 million and growing people if you count both type 1 and type 2. Fantastic question.
Does anyone have a question for Sonia or Doyin? If you do, raise your hand.
Hello, it's kind of the entire panel. One thing that was brought up was a major component to fight these diseases is to raise political will. But oftentimes, as students, it's very easy to feel kind of hopeless to raise political will and kind of, move the bureaucratic chain. So what do you suggest to really, raise political will as students to fight these diseases?
Great question. Sonia.
I think in the settings that I've worked in, working with the grassroots and at the regional level, if you get deep roots, with partnerships at the community level, they'll be the ones that will actually kind of amplify the message and pass it on to the leadership, of that nation. So I think if you can get like sort of a stable partnership at the grassroots level and at the regional or district level, sometimes that can be a little bit less daunting. And in reality, you know, it starts with like a success story. You know, it starts with a doctor seeing one patient turn around, you know, or one woman who's actually able to make it through cancer therapy. That is what convinces, you know, that provider or that community health worker. You know, then the big data follows, but really, you know, just work on a couple of success stories.
Yeah, I think in public health, one thing we haven't learned to do is to look back and learn lessons. We can learn a lot from the HIV/AIDS work. The reason that HIV became a global issue is because the HIV-infected population took it up and spoke out and asked government to do something. So that goes back to what you said, Sonia. The people themselves need to understand that it is about them, and they need to raise it and raise the level, the profile of that issue to the government in their own countries, and then it becomes a global issue. Phil?
It's a tough challenge, you know, to get to certain levels of political, you know, hierarchy to where the difference can be made. But you know, to what Sonia was saying, you know, you have to get on the grassroots. And if it's your voice, you're just one person. But when you have a group standing with you, you can make a bit more noise. And you just got to persist, and then use the connections. I mean, if there's LinkedIn, there's, you know, everyone is within 6 degrees of separation. So who do you know? Who's the person you want to get to, and then who can make the introduction to them, and how do you get to that person? It's really, networking is a very powerful tool, especially at your young age, because you know everyone will talk to someone who's out of college. You know, you are exciting. If you're in college, you know I'm old and jaded now at 33, right? But I love to give advice to the youth, because I see you take it and run with it. So if you just go out there and find out who you want to get to, and then what's the pathway, who do you need to meet, who's going to introduce you to the person that's going to introduce you to that person, and then why. Make a powerful story, have a success story. It goes a long way, because if you can save one life, then you can save a lot of lives.
Thank you, Phil, for saying you're old and jaded at 33, because now it makes me feel like I should be 6 feet underground. I'm quite a bit older than you.
Wiser. Never older, always wiser.
I apologize. I'm going to have to wrap up the Q&A, because I know there are a lot of hands up, but you will have access to them at the end if you want to approach them individually with your questions, because I do want to leave enough time for you to have your working sessions. So I just want to wrap up the panel by giving you a couple of statistics to think about, because when I read these, it really hit home for me how severely devastating these health issues can be to families. In Sudan, families with diabetic kids spend 65% of their household spending on their care. 65%, think about that. So little money left for anything else. In rural Ghana, minimum wage earners with diabetes spend 60% of their incomes on just insulin alone. So all of you in this room have the capacity and the power to make change and reverse those statistics. I mean, think about that. That's within your grasp. And so I hope that you're based on what you heard here, that you're tremendously inspired to go out and make a change. Thank you to our panelists. You were wonderful. At this point, we'd like to encourage you to talk among yourselves, spend 10 minutes doing so. Think about challenges that you thought of today, innovative ways you could approach that, and we would encourage the panelists and our commitment makers to go ahead and circulate as well, and just kind of peek in and converse, and we'll reconvene in about 10 minutes or so. Oh, yes, we'll reconvene in about 10 minutes or so and hear back from maybe a couple of you. And we have some pins to give out, right?
This pin that you see me wearing, pink ribbon, red ribbon, I have several here. If you think you're interested in wearing one, please see me. Thank you.
Thank you very much.